So this time we want to get ready to introduce our speaker for today. But before we do that, I'm going to ask that you encourage your friends to join us. Start watch parties on Facebook, on YouTube, but however, so that they don't miss this vital information about eye care. And I was telling when Dr. Harris, you can come on now. I was telling Dr. Harris when we were looking at the subject matter, I said, well, talking about eye health and eye care is not sexy. It's not one of those sexy titles, It's not one of those sexy subjects that people are breaking the door down and you get, tens of thousands of viewers for. But what he said is it's not sexy, but when you need an ophthalmologist and you got an eye problem, it's very important. So you don't need him until you need him. But thank God he's here today. And I think my wife and I have an ophthalmology appointment in the next couple of weeks or so. And so we've got some good questions that we look forward to asking you in preparation for our visit ourselves. But we want to just introduce him formally on today. Dr. James Harris is ophthalmologist and business owner. In the interest of full disclosure, he is a good friend of mine, and we talk at least 3 times a month. At least 3 times a month. He is a classmate of mine from Oakwood University, and the great class of '86, and appreciate him. In fact, he was our class sergeant at arms. As a matter of fact, I remember him. I can see him sitting on the front row of Oakwood University Church, just like it was yesterday, with his cords on and all of that, and his graduation regalia. Well, he graduated from Oakwood that's not correct. He graduated with a bachelor's in chemistry, summa cum laude. He's a smart friend. I like to have smart friends around me. And he also graduated with a medical degree from The Ohio State University in Columbus, Ohio. Did internship at Naval Regional Medical Center in Portsmouth, Virginia. Residency in ophthalmology at Ohio State University in Columbus. Clinical fellowship in glaucoma at Duke University Eye Center in Durham, North Carolina. He has been employed with the United States Navy, attaining the rank of lieutenant commander, and he was a flight surgeon. Currently, he is a partner at Greystone Eye in Hickory, North Carolina. To his credit and distinction, he is a member of the American Academy of Ophthalmology, the North Carolina Society for Eye Physicians and Surgeons. He is a diplomat in the National Board of Medical Examiners, a fellow of the American Board of Ophthalmology, and was ranked best eye doctor in the Catawba Valley in the Hickory Daily Record, 2010 and 2014. Outstanding. So we thank you for being on with us today, Dr. Harris, and we are so excited about our conversation on today. Welcome.
Thank you so much. Glad to be here.
Yes, sir.
Thanks for the introduction.
Yeah, we thank you for taking a moment out of your busy schedule to talk to us. And so the first question that I have for you today, and I'm sure our audience would be interested too, is what made you want to be an ophthalmologist? Why ophthalmology?
Well, I have to say that the story is interesting. I thought, well, the truth is, and I've only said this out loud in public a few times, and people I knew would not judge me, but I truly think that God whispered it to me.
All right.
It happened when I was in the 10th grade, and I didn't have any medical people in my family.
Mm.
And the first thing about it that triggered me was the way it was spelled.
Mm.
Ophthalmologist has two P's in it.
Yeah.
And I was like, oh, now that's clever.
Uh-huh.
And so that's the first time it ever came to my attention.
Uh-huh.
Later on, I guess it was 2 years later, I got interested in going to medical school after I was told by a good church woman who said, you better go to school.
Yeah.
I'm like, well, Jesus is coming. Well, I'll go to school. Boy, you better go to school. I said, yes, ma'am. And I thought at one time I'd be afraid of blood, do something clean. But in retrospect, I feel like God whispered that to me when I was not paying attention. Mm-hmm. And I always thought about doing other things, but I always came back to this. And I can truly say that it's an honor, a privilege, and great work if you can get it.
All right.
Yeah.
Outstanding. Outstanding. So are there various subsections or specialties within ophthalmology?
Yes, there are. So even though the eye is tiny,
Mm-hmm.
at the time that I was training, at that point I was not sufficiently wise to be humble. And I thought, yeah, this eyeball, man, I'm going to study hard. I'm going to know it like the back of my hand. And the first month of training, somebody came up to me and said, you recognize that there are more books written on the eye than there are on the heart.
Wow.
And at that moment, I knew that I had to buckle down and pay attention.
Yeah.
So yes, there are subspecialties in ophthalmology. We divide up the eye with different skills. There are ones that subspecialize in pediatric eye care because baby eyes are not the same as little adult eyes. I do glaucoma primarily. There are people who are retinal specialists, uveitis specialists who deal with inflammatory, non-infectious diseases of the eye. Some people do strabismus surgery where they're just working on the muscles lining up so you're not cross-eyed. There are subspecialty practitioners with plastic surgery who do lid surgery and face and brow lifts and tumors of the eye, people who've lost an eye to disease or are painful that need to be removed, and they replace it with a cosmetic prosthesis. Neuro-ophthalmologists who deal with brain and other systemic diseases that cause visual or ocular problems. So there are about 8 or 9 subspecialties where you can get additional fellowship training after your ophthalmology training. So,
awesome, yeah. Awesome. I didn't know there were so many, but it certainly makes sense. So I want to move probably from the most common to some of the more complex diseases that we have, or I should say impairments. So there's dry eye, floaters, and tearing, right? So, I've had dry eye before, I've had tearing before, I've had floaters before. What causes that? What do you do about that? What is that about?
Well, that is a question that needs to be broken down.
Okay, break it down, baby.
That's like asking me, I'd like to know a little bit about amoeba, rocket ships, and tires.
Okay, okay, all right.
3 whole different chapters in the book.
Okay.
Let's talk a little bit about dry eye and tearing, since they can be one and the same. So the most common cause of tearing, believe it or not, is dryness of the eyes.
Okay.
The tear film is a very complex moisture layer that protects the surface of the eye. It has very hard to replicate in a bottle recipe of oils and proteins and fluid. But if it's not doing a good job protecting the eye, then you'll have trouble either with the way that you're seeing or with the way your eyes feel. So the most common reason people say they come in with their eyes tearing is because the tear film is not doing a good job. And that can happen because of medications that you take, which commonly cause dry mouth, dry eye. It can happen because of age, hormonal changes. It can happen because of other systemic diseases like thyroid disease or because you've had radiation on some body part. And so those are pretty common. Sometimes it's just older. Sometimes the problem is because of the quality of the tears. Other times you're just not making it fast enough. And so that is the idea. So generally dry eye trouble can be tearing. And when you tell somebody who's complaining of their eyes feel like they're going to water, you say, yeah, I think your eyes are dry. They just want to slap you. Wake up, doctor. I told you my eyes are about to run down my face. We're talking about my eyes are dry.
Right.
But that is the most common cause. Certainly there can be a problem with the tear drainage system. I got some visual aids, but there are some. Have you ever had a runny nose after you sobbed? After
I got a whooping.
Yes, you got a whooping. Right. So in your eyelids, let me get my visual aids. This is what I do for the patients. So there is actually a complex tear drainage system.
Okay.
I don't know if you can see that.
Yeah,
there are little openings in the lower lid and the upper lid.
Yeah. Where
every time you blink, some of the tears move towards the nose and down that system little by little. And so you could have tearing on one side constantly just because there's a clog in the tear drainage system. So that has to be, usually is a surgical fix for that. So floaters, on the other hand, generally come due to the inside of the eye. This part of your eye is hollow back behind the front parts, and you're born with a clear gel in there, and it changes as you go through life. So you start off with clear jello, and as it gradually begins to liquefy and things start to break down, proteins are able to slosh around in there. And if the light coming through the front of the eye is bright enough, it'll kind of cast a shadow in the inside back there, and you'll pick that up as floaters. So most people eventually have some floaters. If they're just kind of, I see them. If the light's bright, I'm outside looking at a pretty sky, then that's okay. If you are to have a whole bunch of new ones all of a sudden, and you're the only one at the table fanning all those gnats, and everybody's looking at you like they need to call for some psychiatric help, then that could be a sign of trouble with the retinal being torn, or a retinal detachment could be a hand needs to be evaluated, especially if there are new things floating in your vision with flashes of light, like lightning strikes, then that could be a sign that there is something changing that needs to be evaluated.
Okay. Now, how about the sun's impact on our vision, right? So I know some people wear sunglasses as a routine. I do, because I'm sensitive to light. So I guess it's individual and has to do with the person's sensitivity. But would you say that wearing sunglasses or not impacts our eyes in any way?
So I'm kind of a detractor on that one.
Okay.
There are people who believe everyone needs to wear sunglasses because of the risk of all these melanomas and the risk of cataract. All those things are multifactorial. I personally think that most of us got more sun. We spend more hours in the direct sunlight without a sunglass or a sunscreen before we finish high school than we'll get the rest of our days. And so a lot of times the die has already been cast as to your risk of, wrinkled up skin or skin cancer or cataracts. But certainly a lot of us as we get older just prefer them. And it certainly is not going to hurt. But at the same time, if you find them uncomfortable or unwieldy, there's no reason to make yourself wear them. But they probably are not hurtful, kind of like wearing a mask. Is few people are harmed by them.
Not harmful. Okay. So hyperopia and myopia, and better known as short-sightedness, farsightedness, and or nearsightedness and farsightedness. So what is the cause? How does that happen? I tell you, it seems like, they try to, every time I go to the optometrist, they say, you can't read that line. We need to adjust. We need to make an adjustment on your. So what causes that? I was so insulted. I went to the DMV and I didn't have my glasses. They said, "Sorry, sir. I tried to read it without my glasses. They said, "Sorry, sir. You cannot drive. I'm going to put a note on your license. You cannot drive without your glasses on." And usually I don't wear them in the day. I usually wear them at night. But they put a ban on me. I said, "Oh no, I don't. I'm feeling some kind of way about this." But explain to us about hyperopia and myopia.
Okay. Well, the focusing system of the eye, like most things in the eye, we've got a good idea about it, but it's pretty impressive. So I'm going to get out my little model here.
Okay.
So the focusing in your eye has to do with, this is the film of the camera in the back. The back wall of your eye is the retina. It's actually transparent like saran wrap, but it's the film of the camera. And to get things in focus, the light travels through your windshield, which is called the cornea. It has a curvature to it, so it helps focus and bend light. And it works along with this other piece, the lens. It's clear, like a little clear lifesaver with no hole in it. And a sucrets maybe. So those two both have a curvature and a certain amount of focusing power. And so the light coming into the eye has to be bent. And if everything is in perfect focus, no matter where on the eye the light comes in, all the light kind of meets together just as it meets the wallpaper in the back. So if the light ray, if your eye is too powerful, then the light rays are bent too quickly and they focus in front of the retina. And by the time it gets to the back wall, the light rays are diverging again. That's what we see in myopia. Basically, your eyes are too powerful. And no matter how much you relax the zoom power of your eye, you're still not clear out in the distance.
And that's also nearsightedness.
That's the same as nearsighted or myopia.
Yes.
So we give actually glasses, you'll see on your prescription a minus number. So you think of it as decreasing the power of your focusing system to push that clear spot back down the highway. Hyperopia is the opposite. Your power of your focusing mechanisms is too weak, and so you're focusing on down the road. And so in order to see, you have to add some of that zoom power. Your zoom power just brings things closer to you. So if let's say a perfect set of eyes was focused at a mile down the road. If you're a hyperope, your eyes may focus 2 or 3 miles down the road. When you're young, your zoom lens is like a National Geographic cameraman. It's huge, and you can see way down the street, and you have the power to bring it up and see it touching your nose.
Right.
But that zoom power weakens every year of your life. By the time you're about 40, you start noticing some changes. But if you're a hyperope, you may find that in your late 30s, you just are starting to have up close trouble. Down the road, you have enough zoom power to bring it in, but it gets too close and you just don't have enough juice left. So that's a hyperope. Okay. Usually they see everything when they're young. Around the late 30s, they start to have trouble, and then they need the reading glasses, and then pretty soon even things in the distance are blurry. Everything is blurry. It's too tiring to keep it clear. And then there are the presbyopes. Basically, these are the old eyes, people who can see down the street just fine, but eventually it gets too close. The kids are like, "Ooh, look, Daddy, look what I see." And you're like, "Oh, yeah,
right. You better hold it back. Come on now."
Exactly. So that's a natural aging process called presbyopia, and it really kind of follows an age-related pattern of decline there.
Okay. So I'm not.
The only one we didn't talk about is astigmatism.
Okay, go ahead, hit that.
Astigmatism means that the eyeball does not focus to a point. Part of the light focuses maybe right here, and part focuses right here.
Okay.
It's just not nice and sharply focused.
Okay.
And so it's almost like having 2 prescriptions in one eye, and it could be corrected with glasses or contact lenses.
Okay. Very good. Well, I'm not sure if this was ophthalmology or psychology, but my wife and I are just the opposite. And we have problems with watching television, so I need a little counsel.
That's sounds psychology. Put your glasses on. Leave them alone.
That's right. That's right. And a brother in the bed, he don't want to have to put on his glasses. I want to relax. I don't want to have to put on my glasses, right? But I guess I better keep peace in the household, right?
Amen. A wise man did speak.
All right. Refractive error. What is that? Refractive error. We know it ain't good because it say error on it, right? What is it?
Everything we just talked about. Hyperopia, myopia, astigmatism. It just means that your things are not focused perfectly.
Okay.
But just about everybody can have something measured in their eyes.
Okay.
But a lot of us don't need glasses for everything.
Okay.
For instance, us myopes, when we get over 45, finally we can still read the menu.
Yeah,
Our friends are like, man,
right. That's right.
Give me the special.
That's right.
I left my glasses.
That's right.
So that we still, without any effort, can see up close. We just can't see across the way.
Absolutely.
So all of that is refractive error.
Okay. Then there is AMD, age-related macular degeneration. What is that? Help us.
So the macula is the film of the camera, the retina, which is the part all the way to the very back here. The macular region is the part in the middle, the part of the movie screen that serves your central vision. That's the macula. And so this is age-related, so it's something of aging that degenerates. That region basically wears out faster than the rest of you. So it is something that is more and more common as you progress through the decades. One thing for a lot of us is melanin seems to be protective from the worst of age-related macular degeneration.
Hallelujah.
So we see it can be devastating because that part wears out and it cannot always be helped. So in a bad situation, it will not leave you in the dark, but it affects the central part of your vision. So imagine being able to see everything except right there. Looking in the person's face, you can see that their hair is messy and they got on a white shirt, but as far as seeing their face, no. You'll be able to go in the kitchen and get a bowl of cereal, but as far as seeing, the dial on the stove or the oven, it's not good. So that's the condition. It's very gradual, but there are two types of it. Usually it's slow. It's just not quite sharp in the middle. Your glasses don't work, and it just progresses very gradually. But sometimes the body tries to repair it. They call this exudative or wet macular degeneration. And what happens is blood vessels, abnormal blood vessels, start to grow underneath the retina as if to repair it. The eye is remarkably made. It has types of collagen that are nowhere else in the body. There's 5 types of collagen in your body, skin and eyes and teeth, nails, but in the eye, there's a type that's not anywhere else. And there's also blood vessels in the eye that are not in your skin or your gut. These blood vessels don't leak out anything, but when these new blood vessels start to grow, they leak and bleed, and they actually cause more trouble. And so people start to have a week by week decline in their vision, and left untreated, it'll leave that blind spot right in the middle, a scar. So now there are treatments for that where they actually inject medication directly into the eye, and it shuts down the blood vessels like Roundup, and is able to dry up the fluid, the leaky blood vessels, and stabilize and sometimes improve vision. So for our European friends, this is probably the #1 cause of legal blindness in retired European people European.
Oh, interesting. Ronnie Vanderhorst asks, can AMD be reversed?
It can be treated. So we've seen if caught when it starts to bleed back there at an early stage, those injections are miraculous. They didn't have that 10 years ago. Okay. They used to just try to make your blind spot smaller. And if you want to see somebody really unhappy, somebody comes in with that condition, and they used to say, well, the blind spot's going to be this big, and they would treat it with laser, and it would be this big. but the person was seeing before you lasered them, and they will never be grateful that you gave them a blind spot.
Yeah.
And so now at least they have good treatment. It doesn't always work, but sometimes you have to have them frequently, like every month or 6 weeks. But that's the best thing we have right now.
So every month or 6 weeks for the rest of your life?
Sometimes. Now, they've got some new medications that have been developed that last for about 3 months. Some people, I know people have been doing them for 4 years.
Wow.
Sometimes it'll eventually burn out where they try to stretch them out. They do these same type of injections for other conditions. There's different medicines they put in the eye, but it can be used for diabetic related problems, for macular related problems, for strokes in the eye, different things.
Wow. I can't imagine getting a shot that often. I had a pterygium removed probably maybe 12 years ago, maybe. And just the idea of something holding my eye open permanently was a problem. That I couldn't blink. That was a problem for me, right? And then the idea that they were going to stick a needle in my eye at all, right, to numb it so that they could, scrape the pterygium off was that was horrifying. And I made it through, and I was able to testify and share my experience with others and let them know that they weren't going to die. But the idea of that is somewhat daunting. So yeah, that's something.
Well, I should say that when you're having usual surgery, the needle does not go directly inside your eye. It goes around your eye to numb up the nerve that serves your eye.
Okay. All right.
So yes, they didn't put it in your eye. Now, when they do those injections, they actually put the needle directly in your eye.
Yeah, that's what I'm saying. That's what I'm having a problem with.
Yes,
and it comes every 3 weeks or so. That's what I'm having a problem with.
Every 6 weeks. But the truth is that people, they numb you up really good ahead of time, and it's very quick.
Okay.
And usually, sometimes people are like, was that it? After the first one?
Okay.
Really?
Okay.
We done.
All right.
Really?
All right. Okay, good. Now, I want to say here, since we're here, we'll talk about a few other things. Well, let's move on, and I'll ask it a little later. So, cataracts. What is cataracts, and what percentage of the population gets that? Is there anything that we can do to prevent it?
Well, a cataract, first of all, is what we call the lens of the eye when it gets cloudy. So, here's my visual aid here. Just like old times. So if you're looking at the front of the eye here, the windshield is your cornea. That's this piece right here. So that cornea is part of your focusing system, and behind the iris color, there's another piece, the lens. So you're born with that. That's your zoom lens, your telescope for your eye. For most people, the cornea stays clear and functional their whole life. But in really everybody, this lens changes as you go through life, for everybody. Nearly everybody develops some level of cloudiness of that lens as they go through life. So everybody gets cataracts if you live. However, only about half of us ever have significant disability from the cataract. So we don't necessarily all have to have cataract surgery. So usually there's 3 types of cloudiness, and generally it just makes things blurry or causes glare or causes you to have double vision like those. Where now some of that can just happen because you don't have your glasses on. So you put your but when you get to the point where the glasses don't work, or it's I've had people with cataracts who drove a truck for a living, and even though they were seeing 20/20 under optimal circumstances, they were like, I'm dangerous. I'm about to quit my job because I feel like I'm going to kill somebody. So the time to remove the cataract really has to do with how it affects your life. And there's no urgency for cataract surgery. You take it out when you feel like it's more than I want to live with. It's just too much to put up with. If they don't come back, that lens of the eye will be replaced with a clear plastic replacement lens that also has some focusing power. So at the time of cataract surgery, you can get back the clarity and the colors that have been distorted and dimmed with the cloudy lens. And as a bonus, you can get back to seeing without the need for your glasses again.
Mm-hmm.
They have different lenses now that can correct your astigmatism. Usually you have to pay extra for that particular lens because it costs like 15 times more than a regular lens. And there is another lens that's called a multifocal lens. So they can give you back the ability to see both far and near with these multifocal lenses. They're not perfect, but for people who hate glasses or have hearing aids that are always in the way, or they're just vain, if they have an appropriate eye, then there is at least technology that can make you see like you're 30 years old again.
Mm-hmm. So. Okay, excellent, excellent. I'm going to get back to Ronnie Vanderhorst had a follow-up question on AMD, and we'll come back to that since we progressed on. Another question: color blindness. What causes color blindness?
So almost always, color blindness is something that you're born with. The retina, the lining, the saran wrap that lines the eye, the film of the camera, has different cells in it. The ones that are most important are the rods and the cones. The cones are centered or very heavily populating the very center part of the retina. So they pick up fine detail, color, fine discrimination. The rods are not present right in the middle, but they start to show up as you get to your peripheral vision. And way out to the side, there are no rods. And the rods are more helpful in dim light or to pick up motion, so that if you see something picked up by the rods over here, your eye naturally wants to turn and use that central vision to identify what it is. So there are different subsets of the cones, the color perceiving photoreceptors, the cells in the retina. And sometimes there's three different primary ones, just like the primary colors you learn about in grade school. And it's very intricate circuitry, but the way we see colors is just like mixing paint in school. Something comes at the right wavelength, and because the wavelength is appropriate, and these subsets of the cones are only stimulated if they see green. And there's other ones that are only stimulated if they see, well, really it's blue and red, and I think, I can't even remember the different ones. But I think there's red and green. Red-green is the biggest lack. So let's say there was a red and a blue photoreceptor that both were stimulated equally, you'd see green. So some people are just born with no representation of one subset of those cones. And so they are unable to see certain colors. They may look at, say, if they have a problem with blue, then they're looking at blue, purple, it all looks the same to them. Or they're missing green. So you're showing them this and then wondering how come it doesn't match. They literally cannot see that color. And so they always say, I'm not gonna, blue, purple, black, it's all dark to them. There's nothing you can do about it. It doesn't really bother you. You see fine, you just don't see those colors. And so the only time it becomes important is for people who have their hearts set on working in aviation or maybe or nautical things where they use different light patterns to tell you if the plane is coming towards you or the plane is going after you out in the dark. And if you really don't see those colors, you're not suitable for that type of work. It's a danger to you. Okay. Otherwise, it's just more, you don't match your colors right with your tie.
Hey, that's a real problem, though. That's an aesthetic problem. That's an aesthetic problem. But we know you don't have that problem because you're one of the best dressers in all of North Carolina.
We're scrubs, man. We're scrubs.
So diabetic retinopathy. How does that work, and what's the cure for that, or the treatment for it?
So diabetes is just becoming more and more common. So they say in the next 20 years, 1 out of 3 Americans will have diabetes.
Wow.
1 out of 3.
Wow.
Fortunately, everybody with diabetes doesn't have trouble, But the longer you have it, the more likely it is for trouble to show up. That's why your family doctor, who now gets punished by the insurance company if you don't get your eyes checked, tends to send you every year to get it checked. Because the retina doesn't have pain fibers. And so if you wait until you're uncomfortable or you're not seeing well, you've waited too long, because the retina, that saran wrap lining, cannot be replaced. It can sometimes be repaired, but you got what you have. And so the idea is to find trouble before it finds you. So generally we screen. And the best way to think about diabetic retinopathy is diabetes is a disease of blood vessels. The way it ages your eye is because it affects the blood vessels. As we mentioned earlier, there are certain types of blood vessels in the eye and brain that are not in your skin or your heart. Stuff that works to fix your skin or to prevent a heart attack, it doesn't work in the eye. And so what happens is the blood vessels either leak, and those blood vessels that should only let out oxygen and fine micronutrients are now letting out cells and fluid and cholesterol. And so if that starts to become soggy, I like to call it, near the center of the vision, we call that a diabetic macular edema. And if there's certain criteria as to when you treat and when you don't, they call it clinically significant diabetic macular edema. That's a phrase, a mouthful, but it means something to the eye doctor. It means the leakage of fluid and blood and cholesterol is close enough to the center of your vision that we should treat now. And hopefully we catch it before you catch it. And so there's treatment with those injections or laser to try to seal up those leaky blood vessels and prevent loss of vision. The other way it affects the blood vessels is in your eye. If the circulation starts to suffer, the body becomes less efficient at delivering nutrition to the retina. And it's very highly metabolic. It needs its lunch. And so if it's getting kind of starved, it starts to send out a chemical SOS signal. It's called vascular endothelial growth factor. And there's different subsets of it. But basically, it makes things grow. Think of it like fertilizer. And so in your eye, if the circulation is poor, it starts to make new blood vessels. Kind of like if Highway 101 is on fire, Nosakhere, you might get off on a side road and go get around the
That's
trouble.
exactly what I did. I did that. What was that?
So
in
in your eye,
I did that in May or June.
I remember the story. So in your eye, if the circulation is poor, the body starts to open up new highways. But these new highways are not fit for the eye. They are leaky and they are weak. And so they tend to make a mess of the retina. That delicate retina starts to get pulled on because it has, these blood vessels have a elastic quality. So they tend to distort and pull on things and leak out blood in your eye and just cause trouble. So those are problems that are highly likely to cause visual disability and blindness. Now, if you get these new blood vessels growing in there, there's laser and these injections. And about 10 years ago, when that story about Jackie Robinson came out, Jackie Robinson died early of complications of diabetes. He went blind in one eye, and he was one of the first people to have laser for this diabetic complication in his other eye. It was like at the 70s. And so you like to think that saved him from not being able to see at the end of his days. But the laser, I think, is very helpful for the higher risk complications, the leakage, and some of these other complications. These injections have actually supplanted the laser to manage those.
Okay, good. So we know that we can, through diet, exercise, etc., we can control our diabetes. Even if a person has it in their family, genetics, that's only about 10%. And so it can still be controlled. So it's not so much our, genetic code as much as often it's our zip code more than anything else, right? But so we get that. So, and we've been told for years that carrots, beta carotene, and things like that. So, what other kinds of supplements or nutrients do you think is helpful for us to take orally or to ingest so that we can have improved eye health and wellness?
Well, the truth is just what you're preaching and doing, what they've told us from our youth. Eat your vegetables. The more colorful, the better. And we know that different things change. You know, the recommendations for good health change. Sometimes we're supposed to take an aspirin, and they say, no, you quit taking that. We look at the food pyramid from the 70s, right? Now they've turned that completely upside down. One thing you cannot lose on is eating vegetables. Carrots are good, but the truth is that there is you can get, if you're vitamin A deficient, then you could have blindness from that. But it's almost impossible, even eating at McDonald's, to be vitamin A deficient. So carrots are good, but not because it's a source of vitamin A. It's just because all vegetables are helpful and healthful. And basically, if you're eating your vegetables, man, you are saving yourself from a multitude of problems.
All right. Thank you so much. So let's move on to amblyopia. What is that?
So amblyopia, so there's three types of amblyopia. Usually people call it lazy eye.
Okay.
The only ones
we all had that friend in school, before things got politically correct, back in the day, you talk about lazy eye, such and such lazy eye, but go ahead.
Yes. So the one that we know the most about is strabismus. That's where there's a misalignment of the eyes. They're both not looking the same way. One eye is drifting out or drifting in. That's strabismus.
Right.
So there are actually 6 muscles that move the eyeball around, and there's just one that's pulling too tight. Sometimes if you're, as a child with that, if you're hyperopic, well, I'll just say, sometimes if you identify that as a child, it's just that the child at that point needs glasses. And you sometimes can cure their strabismus with glasses. Sometimes the strabismus can lead to amblyopia. So this is really what amblyopia or lazy eye means to us. It means that you're looking at 2 equally healthy eyes, and for some reason, one eye won't see. It's very poor vision. And that happens because something is keeping the 2 eyes from working together during the developmental years. So it could be that one eye is looking at mom and one eye is looking at the wall. Well, your brain is trying to take this vision, and it wants to just do that. Anything that keeps it from being able to lock in like a magnet, because your brain does that the first week, it causes your brain to have to choose. There's visual confusion. And so if this eye is drifting out instead of looking at mom, basically the highway between your eye and your brain is being paved from the time of birth to about 8, 9, 10 years old. So if something interrupts the paving of that highway, you'll end up with one eye that has normal vision, the other eye that doesn't. So if this eye has been drifting out and not being used, it might see a little bit, but it's not going to be 20/20 like the other eye. And if it's caught later or fixed after you're 12, then even though it looks good in the mirror, it still doesn't see any better. It's amblyopic. Another reason for amblyopia is because one eye is just blocked. We got those other people in the hood from Fat Albert where one lid is just drooping half closed. Sleepy eye.
Right.
We call that ptosis with a P. And so if that happens if it's me now, I get hit in the eye or accident, my lid is drooping, it's cosmetic. Sometimes visual where I can pull it up and I see better. And so you fix that. But the eye underneath still is good. But if you have a ptosis as a child, then that can also keep you from paving that highway. And even though they lift the lid up when you're 15, you got high-speed internet over here, dial-up over here. You got 60-inch plasma screen over here. You got rabbit ears with aluminum foil on the top over here. The quality of the vision is never good. Another reason, more commonly, where the kid looks normal, but they're sent in because they screened them at the pediatrician or the school, This eye sees without glasses, this one doesn't. If you catch it early and you find out that this eye sees without glasses, but this eye has a significant glasses correction, if you can give them the glasses and work with them to give this eye extra homework, you can get that paving done before the road is completely finished and there's no help really to improve it. So those are the three types of amblyopia, talking about the vision more than the appearance, but it's keeping the two eyes from developing together.
Okay, very good. Now, in 2012, you wrote a paper, co-authored a paper on Keracotonus. Keracotonus, yes. And so what is that, and how does that affect us?
So that was some research I was involved in when I was in training. Keratoconus is a condition that affects the windshield, the cornea. And it usually strikes during your adolescence. Usually it gives you a really crazy glasses correction that has, even when you get it, it just doesn't work very well. Sometimes it can be mild where glasses or contact will work. Other times your cornea is so distorted that you need a corneal transplant. So it's usually it manifests in the late teens or early 20s. But, you know.
Excellent, excellent. So the eye is a particularly powerful organ, right? For black people, I know, because when I was growing up, everything would put your eye out, right? So, boy, watch how you riding that bike. You put your eye out. You fall and put your eye out, right?
Right.
You don't want to throw no rocks because you put your eye out. Of course, you could have an eye problem with that. Not likely, but you could. Everything is around the eye. So much, around the eye. And so with that, I want to ask the question of the diseases or conditions that we mentioned, or perhaps others, what are African Americans more likely to have, and what conditions more readily impact us as a black population?
Well, first of all, why is it that we appreciate our vision so much?
We need it.
We need it. Why do we appreciate it? Why don't dogs seem to be, they're into their nose more than they are into their vision? And it's because your eyes don't really do the seeing, your brain does. And so the part of your brain all the way to the back is called the occipital lobe. And about 1/3, it's like 25% of your whole brain is involved with vision. And so when you think about how much real estate in the brain is completely consumed with the color and spatial orientation and discrimination, I think that's why people will give up anything before they give up their vision.
Yeah, my mother's concern was about 25% too.
Well, the truth is that you only have to know one person who was cutting grass, and they hit that rock, and it hit something and it put their eye out. Or you had one person,
story, just one story,
playing paintball, and they got hit in the eye,
right? And
now they can barely, and you want to see somebody who's really sad,
right?
You'll see a guy, had a patient, beautiful little 10-year-old girl outside working with her dad, putting up a fence, didn't have on eye protection. He puts the baby's girl eye out. So now she can see the big E, and, where the eye protection, where the hearing protection, because, you see people, I've had patients, I've been a roofer for 40 years, and I never wear eye protection until that one day, that nail in your eye, and 3 surgeries later, So, got to say, protect an ounce of protection. All right. Now, on to what affects people of our, from the African or diaspora, or our Latin brothers and sisters, non-whites. Glaucoma is the big thief. So glaucoma is notable because it doesn't hurt and it doesn't make you blurry. And so if you have symptoms for glaucoma, occasionally it could be painful, a little mild headache, but it's so sneaky. I've actually had people come in blind. I was playing with my baby girl and she was playing peekaboo and I was like, wait a minute. I can't see.
Wow.
It was glaucoma. Wow. They had a fist fight in high school. Now they're 40 years old. You know, it cleared up after the swelling went down. I never wore glasses, so I never went. And was off the eye chart, no bringing that vision back. Or sometimes, you know, you just don't worry. So that's the one thing we worry about. Glaucoma is a condition that affects the optic nerve. It's this cable that carries the vision from your eye to your brain. Usually inside the eye, there's a clear fluid that's produced, and it's under a certain tension. There is a drain. Well, beside the cataract, there's a little pump back there that makes fluid, and around the iris, there's a exit channel. The fluid does not mix with your tears at all. You don't feel it, but if something happens to your drain and the fluid that's being produced can't get out, the pressure will rise gradually in the eye. And if it's high enough, it acts as if it's choking out that cable, taking the vision to your brain. And the big problem is you can't replace that cable. And you can't even fix the cable.
Wow.
It is what it is.
Wow.
So when we identify glaucoma, our job is to just protect the vision that is there. Any improvement in vision is a blessing. Wow. So that's something that it affects us disproportionately. And only about 1% of people will have glaucoma. So that's about 3.5 million people in the United States, but only about half the people know they have it. And so unfortunately, if you come in later, then it takes more heroic measures to try to preserve that vision.
Right.
If you come in early.
Now, why is it that it affects Black people more, do you think?
Some of it is genetic.
Okay.
Some of it is that we just don't get caught as quickly. But even in all Caribbean nations and in Africa, there's something genetic about us that tends to give us particularly severe consequences from glaucoma. Okay. Most people won't go blind, but if you look around the world for blindness that cannot be fixed. So most people in the world who are blind, it's because of cataracts. And with a 10-minute surgery, you can make them see and become productive citizens again. But when you find things that can't be fixed, glaucoma is like top 2.
Wow.
It's blindness and it's Stevie Wonder blindness. You don't have what you need to fix it. Wow. So glaucoma is something that even if you don't wear glasses, when I see people who have severe glaucoma, I tell them, tell your kids who are 40, go get that. Do me a favor for Mother's Day. Go get your eyes checked, even if you don't need glasses, just so they can identify trouble while they still have good vision.
Good point. Good point. So should we go once a year? We should go once a year?
Not really. If you don't need glasses or contact lenses, this is my personal. This is not sanctioned by anybody who wants to sell glasses. But I usually have, usually the kids get screened pretty well. So if you want to get your eyes checked once when you're in first grade or kindergarten, great. Sometimes I'll tell them to come, let me check the eyes when you graduated from high school. Thereafter, I say, come every 10 years, whether you need it or not, because usually you won't see them until they're 45 and they've never needed glasses. And all of a sudden, I'm like, what? I can't see that. Now they come to get their eyes checked just to make sure. Some of them don't. They just get some reading glasses. But we just want to check the health of the eye. As long as it's something that glasses will fix, well, wear them if you want. Don't wear them if you want. No problem. But you need some screening, and as you get older, you need to go more often. So, because stuff comes when you get older. Yeah. So usually in the 40s, if you don't need glasses, come a couple of times. Usually I'll say if people have a family history, come every couple of years, whether you need it or not. If you have diabetes, come every year or two, whether you need it or not. When you get over, 55, 60, you should probably be coming every 1 or 2 years, whether you need it or not.
Yeah, that's that category I'm in right there.
Yeah,
1 or 2 times every year, whether I need it or not. That's right.
Yeah, if you got risk, go every year. If you got diabetes, go every year. If your dad's got somebody went blind in your family, just go. when you're over 65, you generally just go every year.
Yeah, yeah. I just choose to be proactive. I mean, it costs me, maybe 30 minutes to get there, maybe an hour in there, and 30 minutes back home. 2 hours to ensure, my health and wellness. So, excellent. So Torrance says hello. And then let's see who else is asking us. Remember Torrance Crutchfield. And yeah. So let's see who else. Back to Ronnie's question. So Ronnie Van Horst said he was told that getting a prescription for glasses won't do any good for his AMD, and that was true. Why didn't the prescription work? Why doesn't the prescription work for AMD?
So this, if you think of your eye like a movie theater, the movie screen is the retina, and the part in the middle is the macula. So most of us are not looking at the wide screen on the edges. We're looking right at the scene in the middle. And so this, if you have a problem with the middle, think of it as if you're showing your movies on a wrinkled bed sheet instead of a fancy IMAX theater. You're watching it on the side of the garage with aluminum siding, and the picture quality is just not very good. So no matter what kind of camera you get, what kind of telescope you shine the image on that barn with, the problem is not in the lens, it's not in the camera, it's in the film of the camera. And if you had a good movie screen right in the middle, if we could repair that, you could restore the quality and color and discrimination that's missing. But until we get an opportunity to replace that retina right in the middle, it just doesn't work. So, given we were laughing about how we make lawyer jokes all the time. That was really common earlier in my life at one time, until you get sued, or until there's a problem.
That's right.
And you need a lawyer, and all of a sudden it's not funny. It's not funny at all.
Right.
You can make plumber jokes.
Right.
About the way their pants sag and too much until you need a plumber. Now you say yes, sir. To thank you for coming. And so this is the problem with this eye problem, that we just need better things to repair the retina. But that's why it doesn't work, because that's not the problem. The glasses are not the problem. That's not why you're not seeing well. And especially after cataract surgery, and you've done everything to the eye that you can, but there's still a problem there that we can't fix, and so it limits.
Your classmate, Dr. Rochelle Parker, says hello and happy Sabbath to you.
Jody!
She's enjoying the conversation. All right, let's see. I had my eyes about to go blind looking at these threads. Let's see. So we have a friend who says that her eyes started to have problems when she used blue tint in her prescription. And she went to the doctor, and the doctor said that the red tint would be better for her and not irritate her eyes as much. Had you heard anything along those lines? So that's tint in the prescription.
That's what it sounds like.
Yeah.
So now that we are spending so much time in front of screens, there's a whole industry that has been developed around different blue blocking lenses and tints and glasses to diminish eye strain and eye fatigue. There is not a lot of strong science with that. So I think that it turns out for a lot of people to be anecdotal, patient preference. You want to make sure that your eyes are not dry, because spending time at near work tends to put stress on that tear film. So if you're a person who starts off in the morning doing great, and then after lunch things to become difficult, and then by the end of the day you just want to close your eyes even if you're not sleepy, that is typical of eye strain, dry eyes. So lubricants some extra omega-3 oils in your diet, or sometimes prescription eye drops, Restasis and Xiidra, can be part of the remedy for that. Outside of that, the tint in your glasses is much preference. If sometimes people really who have problems with their eyes find that that yellowish tint in the lens is very helpful. But if you don't have things, you can wear it at night and day. So if you have problems with glare and sensitivity, it's functional even in low light circumstances. But in great degree, those things with the tints in the lenses is just up to individual preference.
Okay. And you were talking about looking at screens. I developed the onset of my pterygium was in the seminary. I had a monochrome, those green monochrome screens that I did all of my typing on, and it was through, eye strain. That's when it started to develop, actually. Does that make sense based on the science?
Well, more commonly, we find that people who grew up or spent a lot of time outside in the sun and wind, or grew up near the equator. If they're from Miami or Costa Rica or Mexico, and they spent a lot of time outside, or they're golfers and surfers, despite how much you spend time outside, the closer you get to the equator, the more likely it is to show up. So sometimes even people in their teens, in early 20s, have significant pterygium, and you find that they immigrated from El Salvador, or that they grew up in Miami, or they're from the Caribbean, or they were like my dad.
I'm from Watts.
Maybe people who spend a lot of time outside. So everybody's different, and there are exceptions to the rule.
Yeah.
The big risk factors are proximity to the equator, time outside in the sun and wind.
Okay.
So those are the kind of people who generally get them.
Okay. So the monochrome thing was not likely it then? Probably not.
You're special, man.
I'll take that. All right. So Elder Nola says her husband likes to watch TV with the lights off. Now, when I was growing up, they used to say, boy, turn that light on while you watch the TV. Your eyes go bad, So she's asking, is that a problem with his eyes, or can that cause a problem with his eyes, watching the television with the lights off or the room dark?
Well, the truth is, no.
Okay.
It won't hurt your eyes.
Okay.
Now, if your mama told you to turn the light on, or
turn it off, mama told you to turn it off,
you might do better to watch the TV with some ambient illumination. But as far as hurting your eyes or leading to some serious trouble, no, that won't do it. Of all else, if in doubt,
right,
listen to the woman in your life.
Do what mama say. whether it's your children's mama or it's your biological mama, do what mama say, right?
Do what mama said. Amen. Amen. But don't worry about them hurting their eyes. That won't do.
All right. So Ella Shepard is asking the question, are there eye exercises that can help with sight issues? A few years back, Ronnie Vanderhorst actually introduced me to a book. What's that book entitled? Vision for Life. I can't see the author's name right now, but I'm sure he can type it in. And he has a battery of exercise. I think I mentioned that to you too before. A battery of exercises wherein he has had good results with people having corrections and reversals on some of the conditions that they've been experiencing. So in your research, in your practice, have you come across things that people can do to improve eye wellness and health?
So this is a field of endeavor that has really changed over the last 20 years with all these wars. So when I was training, it was really dismissed. Eye exercises, except for very specific things in children sometimes, it was just poo-pooed. But now, since we've had all these veterans come back from these wars over the last 20 years with devastating facial injuries, we have found that things we thought would not improve have actually responded to vision exercises. Amblyopic eyes, this has always been my bad eye, but now it's the only one I have. And we have been able to witness plasticity with the neuronal system, where things that were thought to be a lost cause have actually responded to those things. Some of it has been very helpful. So I have to say that I am not trained and have no real expertise in that, but I have seen enough examples that I know that there are certain exercises, some of them computer-based, that have been shown to be effective in improving visual performance.
Okay, good. How about proximity to the television? Kenya Gray asked about proximity to the television. We were told, boy, you get back, girl, get back from that television. You're too close. And besides, I can't see. You ain't made out of glass.
That's it. I think your big head was in the way, and I'm trying to watch the game. Sit back, boy. You know, I think some of it, I'm not really sure about the radiation that these screens are emitting and how that might affect our health over time. But that would be my only concern. It's not going to do anything particularly clinical to the eyes, but as far as our overall health, who knows?
Yeah.
A lot of it is, especially if it's a kid, you just make sure they can see from the couch.
Yeah.
Some of them need some glasses sometimes, but if you've got normal vision, some of that is just the proximity is kind of preferential.
Okay.
And again, if the woman in your life says sit on the couch, get up.
All right. So when I'm at the movie theater, right? So I've got that sweet spot. So I can't be down in front with the, with the handicap, because that's too close. It's hurting my eyes. In the front row, I can't see anything. It's too close. And then I don't want to really be too far back. I got my glasses on. I don't want to be too far in the back. There's a sweet spot right in the middle. So is that just a matter of preference, or does that have something to do with our actual vision? Or both?
I think it's a balance. It's probably both. Some of it has to do with your particular vision and your refractive needs. Some of it has to do with technology, because if you get too close to things, you can see the pixels. You need to back up to get the real image the way it was designed to be. Certainly, a lot of that is engineering driven.
Mm-hmm. Okay, good. So your classmate Robin Parker Langley says, Nosakhere, you was outside, the wind was blowing, and you was in Watts. Leave it to your classmates. Your classmates will fix it up for you, straighten you out. So, I got two questions, and thank you so much for chiming in, our audience. Let's see, Brother Ben, what can be done to correct and improve retinal dystrophy? Retinal dystrophy? Dystrophy. You see it?
Oh, retinal dystrophy. Yes, ma'am.
Dystrophy.
Yes, sir.
I didn't pronounce it right. Dystrophy. Yeah.
So a lot of these retinal dystrophies turn out to be in the family of macular degeneration.
Okay.
Some of them there are really no treatments for it. So there's so many different ones. One of them is like cone rod dystrophy. There's Best's disease. There's retinitis pigmentosa. These are all dealing with the retina. So number one, you got to know that this is the only retina you have. And you're lucky if they have something that'll help manage it, fix it, improve it. Sometimes there's not. And so these are the kind of diseases in general that are likely to be improved once we have better translational medicine with things that are gene-based, or some of the electrical nanoparticle engineering feats that are being worked on. So right now, it just depends on what specific retinal problem you have, and if there's anything that's out there that's proven to be helpful. But the things right now that for me separate blindness from blurriness, truly cataracts can make you blind where you cannot get around. But because we can fix it, I just say you're blurry. But there are certain things that we cannot do anything about. And they tend to be the nerve tissue, the retina and the optic nerve, which is what glaucoma affects. Those are nerve tissue. And, you know, the optic nerve basically is a part of your brain. That nerve goes from the eyeball through the socket and hooks directly into your brain. And so the fluid that bathes that back part of the nerve is the same fluid that your brain and spinal cord float in. That's why sometimes the eye doctor can look in your eye and say, you need an MRI, or this is an urgent situation. This is not just a glasses problem or a cataract. And these other symptoms you're having, this needs to go to the hospital right now. It's because we can see that that nerve is being affected by something that just doesn't add up. It needs to be evaluated. So the nerve and the retina are things that we struggle with, and we have to just look to better technology. You just say, well, you know, God, you made this one a little bit complex. So when I read those Bible stories about God healing blindness, I'm not thinking there was a guy who had cataracts. I'm thinking God went into these people's eyes. They were blind from birth. And he did a David Copperfield. He had y'all looking at the mud and the clay.
Yeah.
When he was doing something just ridiculously. He used that Genesis 1 power to restore vision to a man who'd never seen before.
Yeah.
That's retina and nerve problems.
Awesome. You know, does the Bible say that the eye is the window of the soul? If the Bible doesn't say it, it's certainly a familiar adage. Can you look at people as a eye doc and say, "Ooh, you're a liar"? Boy, hey, look at their eyes and say, "Woo, you've been stealing all your life. You just been stealing."
No, they don't teach you that. My wife can, though. My wife is good at that.
She got discernment. Hey, she got that's some spiritual discernment that they didn't teach you in ophthalmology school, right?
That's the truth. That's right.
That's awesome. So Kenny has a question. He said, awesome presentation. Can you speak generally to the capacity of adaptive equipment to assist with activities of daily living for people who are visually impaired?
Yes. So now these engineers, they are coming out with all kinds of visual gadgets. And so over the last 5 years, they've developed different eyeglass wear. Well, we all remember the Google Glass came out, which was kind of a flop. But now there's a series of engineers working on these things. One of them is a pair of glasses, basically has 2 cameras in both eyes, and the images are then streamed or shown onto your retinas. And so it was developed by people who, this person had college students in his family that were visually blind by a form of macular degeneration that shows up early in life. And over the next 10 years, he developed these glasses so that they could read natural print. And now there's another one that's come out. This is happening fast over the last year. There's this pair of glasses that comes with an ear device. Even if you are Stevie Wonder, you can put them on and it will read for you. Oh, the menu says that we have avocado-based dressing with, it will read to you in your ear where nobody is disturbed by it. And there are other things that are helping you with the vision, but there are other technologies that's really going to give people some independence. They're working now with, the eye doesn't do the seeing. The brain is where the vision happens. So they're working at trying to improve the connections between the eye and brain, bypass the problem. Some of it has been very invasive where they were doing neurosurgery to implant electrodes and stuff to your eyes. But I think as technology continues that there may be an opportunity to bypass the eyes and get visual information wirelessly to the part of your brain that processes information. They've done some. and the person was completely blind, and he was able to see like X-ray vision. It wasn't the vision we grew up with, but he could see like shadows. He could say, that looks like Nosakhere Thomas. Oh, I could tell by that nose, or I could tell by your gait that you walk like my wife. And so there are different things that are being worked on. They're all very challenging and have their limitations, but there's stuff that's coming. And some of it's kind of expensive, but I know those glasses that were $20,000 is half price now. And then there's these other prototypes that are $2,000. I have people in the office every week buying a pair of progressive lens eyeglasses for $1,000. So if you're blind, $2,000 is nothing if it can make me read the menu when I go out to eat.
That's true.
So these things are improving, and there'll be an app in the Apple Store pretty soon, I bet.
No doubt, no doubt, no doubt. Very good. So last month, was it last month? No, it was September. So August, Dr. Milton Brown was on, and as you know, he talks to us. He comes on as our COVID consultant once a month. He'll be on next week, as a matter of fact. And I think Brother Ben asked him, he said, if you were traveling, what would you do as a precautionary measures? And he said, I would wear a mask and a face shield. So, so we do know that in rare cases, COVID is contracted through the eyes. So what has your study yielded about that? And what can you tell us about eye care in the era of COVID-19?
Well, it turns out that because of the proximity that we have with our patients when we're looking into their eyes, that just after ER physicians and critical care pulmonary specialists came ophthalmologists and dentists as far as their risk of exposure. So in our offices, we limit, first of all, who can come in the building. Y'all stay in the car, patient come on in. We have people that come in to clean things that people hold on to, like handles and chair rails, at lunch every day as well as at the end of the day. We clean everything after every patient, trying to just limit exposure, limit opportunities to transmit. But aerosolized and airborne particles are the most serious. So the face mask is mandatory. We wear them. Everybody who comes in must wear them. And then we have a little shield that we have on the slit lamp while we're examining. It has been reported that COVID can be manifested in the eyes as a red eye problem, a conjunctivitis. In our experience, it seems as if that's not a presenting sign. What I mean is nobody's coming to the eye doctor saying, I feel fine, but my eyes are red, and then next week test positive for COVID. Usually they're already very sick if they're having the conjunctivitis. And so even though it can be spread that way, that has not been something that we clinically have been witness to or highly concerned about it. Some of us wear glasses, but I generally don't when I'm working because it impairs my ability to examine carefully. But all the other things we do. So I think basically possible, probable. I would do what Milton Brown tells me to do.
Kind of like mama, huh?
Absolutely. But I think that the main thing is to prevent exposure, and if we can all do that for one another, yeah, our eyes and everything else will be better.
Okay. Well, this is the last question, actually the last question from the audience that we have today, and then I have one question for you. And this has to do with the idea of iridology, and certainly not anything you were taught, in your regular medical school practices, and it tends to be more integrative or more holistic or naturalistic or whatever. And I've seen conversations about that where some have said that's quackery, right? It's not rooted in science or whatever have you. But what is your thought about it, and how do you relate to it based on your experience and your research?
So I have only had anecdotal exposure to that, and I have to just say that I think I am biased because I have been trained in Western medicine. But I do now find that there are things I simply wasn't exposed to that work. Now, you know, a lot of the physicians are brought up in the osteopathic tradition. They're DO medical providers, and they do different things with manipulation. I think that for all treatment, getting the appropriate diagnosis is a prerequisite to getting the appropriate treatment. And I, at this point, just am not able to really comment on the power of iridology as far as a diagnostic tool.
Okay.
I've heard people give their stories about they looked in my eyes and they said, you know, your liver is not
right.
know, it just sounds absolutely fantastic to me.
Right.
But I think the
it's
thing
almost
to do
prophetic, right? It's almost like a word of knowledge.
I really don't know. So I try not to be unnecessarily dismissive of it. But for me, example, when people come to me and they say, you know, oh, I stopped my eye drops for my glaucoma, but I've been smoking that weed religiously. Check my eye pressure.
Yeah.
Well, we check it.
Right.
And if it's not doing well, I'm like, okay, this is not working. If it was working and you preferred to smoke this imported weed, now we've tested, you know, the hickory supply. You got to get it imported from some different soil or something. These woods are not going to provide the chemical necessary to manage your glaucoma. But we tried. They said, no, they said this will work. Well, let's try it and measure and see if it works.
Yeah.
And so if somebody told me that your liver is having problems, well, I would be trying to go get some liver tests and maybe an MRI or CT to try to confirm that. Mm-hmm. So that would be a way for me to develop an appreciation and confidence in those skills. But those are examples of, you know, things that you can evaluate for yourself.
Cool. And I'm glad you said it like that, because we know that there's what's taught in conventional medicine, you know, curriculums. We get that. I asked my doctor, well, what can I do about like that? He said, I don't know what to tell you. I said, well, what's the cause of that? He said, I don't know, you know. He had no answers for me. You know, that was unacceptable. But so my approach is integrative, really, right? So and as you said, let's do the naturopathic, the holistic approach, and let's test it. You know, let's test it with the science. What is the science saying when we look at our next round of labs? What you know? So I think, you know, because I think God gave us both, right? And to the extent one or the other doesn't impair us or make us worse, I think they can be very helpful to us. Last question. How has your faith informed your work, generally speaking, and maybe on a day-to-day basis? What would you say to that?
Well, I think that one thing, we're all on this spiritual journey, and I just recognize that, you know, work is such a blessing for me. I think, though, there's just a blessing in being able to create order out of chaos, beauty out of disarray. So maybe your calling is for music or gardening or cooking or painting, but whatever God has given you to make the world a better place is a blessing to you. I also have learned that it's a privilege to do things that people appreciate. I think in medicine, the thing that's so helpful for some of us who are not noble on the inside is that things that align for our benefit also incentivize us to do well by somebody else. So for instance, some days you're just into things, but you just have these experiences where I had this old lady who was sitting in the chair and we were making preparations, and she told me that she had cancer. And that, she probably wouldn't be back for her next appointment because she had decided she wasn't going to take the treatments. She said, I've taken care of too many people with that chemotherapy, and I've decided to go visit my people down in wherever, Texas or Arkansas. And then she said, her visage changed. She said, I've just decided in my spirit that I'm going to live every day that God ordained me to live. The room just changed.
Yeah.
And so, just pray for me, she said. And so we stopped right there and we prayed.
Awesome.
And when I saw her obituary come by, all I could think of is there was a soldier right there.
Yeah, yeah.
And other times we'll have people who just need you to listen. And I can just simply listen.
Yeah.
And other times I had these deaf patients. I've had a series of deaf patients. And she had already lost one eye to glaucoma. We had to do surgery on the other eye. She comes back at a month after everything's looking good. And she said, you know what? The other day I was driving down the street and I saw at the end of the horizon, the mountains, and I started crying so hard. I was so grateful to God. I had to pull over to the side of the street. And so she was there in our chair just saying, thank you so much for restoring this gift of sight, because if I can't see, I can't talk. I can't communicate. And she had tears coming down her. And I was just like, basically, what you're able to give is what enriches your life, not what you get. And so God is using this gift of ophthalmology to, we go on mission trips and we see people who don't have any money, but they got family and they got faith and they have community and they are just so gracious. And, they come back and they bring you some eggs because they can see, or some oranges. And it just makes you recognize that God is giving you something that you can give. And that is how you measure a rich life.
Amen.
And so I don't have a lot of talents like some of y'all. But I've been given this training. I've been given this thing. This is a tool that God gives to me. So I just see his hand. And it's not what you do, but the spirit in which you do it. It's not what you give, but the spirit in which you give it.
Good
and
stuff.
So God is helping to grow me up to be a better person because of the gift of cataract surgery, ocular surgery. So that's my testimony today. It's just a blessing to go to work.
Good.
And we were out for 7 weeks during the COVID. We had shut down. So I was pretty sure at that point that I'm not ready to quit, Lord. If I can go back. So, thank you.
Gave you some appreciation. Well, awesome, Reverend Harris. We appreciate your ministry, the ministry of eye care and all that you do. And you're also a good husband. You're a good father. You're a good bass. You're a good baritone. And a soloist from time to time. So we appreciate you. Fantastic information. And we will not no longer castigate and marginalize ophthalmologists and eye doctors because we need them so much. And we appreciate you for stopping by and sharing this good information with us. All right.
Excellent.
Well, thanks again. Doc, please give Nicole our regards. Bless you. And
Thank you so
we'll
much.
talk to you soon.